these are notes 5.10 on injectable medication administration. So we are going to be looking at the different degrees of the angles that we're going to hold our syringes at, how we're going to solder syringe and needle, and the actual anatomy of a syringe. So the first thing in your notes, you are going to draw a syringe. Okay, so we want to know what these different pieces of the syringe are, what make it up, as well as what makes up our needle. Okay, so we have two different things that are going on here. One, we have a needle. Two, we have an actual syringe. Okay, so the important parts with your syringe is the tip. So we have, this is what's called a lure lock tip. So you guys can see that it has this little like curvy twist like a screw. So the needle goes in, twists, and locks. Okay, so it locks in there. Then I untwist it and it unlocks. Or we have a catheter tip. So there's no twisty action. I would just push my needle on and then it's secure. Okay. And to undo, I still kind of push it and twist to release some of that friction and allow it to be easier to be removed. With our syringes, so we have the tip. Then we've got your plunger piece, right? So the black part is the plunger tip. So, and this is where the important piece comes from, because at the very top of your plunger tip is where you're actually going to decide how much medication is in the syringe. So I'm looking at the very top of the rubber part, and where does that match up to the line on my syringe? So here I have 0.5 mLs or cc's. There I've got 1.5 mLs or cc's. So that's where I'm looking at. I'm looking at the very top because there's all that liquid is from here to here. Same thing on this one. So here I have 0.3. Here I have 0.35. Okay. So it's important that I do pay attention to those volume markings. Here is 0.5, 0.6, 0.7, 0.8, 0.9, 1. But on this one, is it the same? 0.1, 0.12, 0.13, 4, 5. It's not the same, right? So in this case, it goes up by 2. So it's 0.22, 0.24, 0.26, 0.28, and then 0.3. So it's definitely important that you are paying attention to those volume markings. The whole piece where all the liquid is going into is the barrel. The flange is the part that you get to use as support when you're injecting or even pulling back on, okay? And then this, of course, itself is the plunger. So that is your anatomy of a syringe. And then we're going to look at anatomy of a needle. The different colors of the needle hub. So this piece is a hub, okay, that colored portion. That's going to actually let us know what gauge the needle is or the thickness of the needle. The smaller the number, for those of you that have gotten piercings or know anybody who's like gauged their ears, the smaller the number, the larger the hole, versus the larger the number, the smaller the gauge, okay? So that is a little bit backwards. So we also then, so there's our hub. This is a fairly small number, right? But it's got a large hole in there. And this is what we call, if you guys can kind of see how it goes on an angle, that's the bevel side up. So we always want the bevel side up when we're administering an injection, okay, or when we're drawing blood. So bevel side up, the lumen is the whole part, and then this giant metal piece is the actual shaft, okay? Then when I'm capping needles, I'm actually always going to cap one-handed, just to be safe so I'm not poking myself. So that's something we do as a precaution. Again, we don't want to stab ourselves with the needle. So that's your anatomy of a syringe. Make sure absolutely that you draw both. We're not going to memorize the colors with what gauges they are. You guys will get pretty good at that, though, as you're in the facility. Okay. Then we have the routes for injectable medication. You will be responsible for knowing the sites of injection. So where are we going to put an intramuscular injection versus where are we going to put an intravenous? What are the veins? Where are they located? And whatnot. So muscle groups versus veins versus that extra tissue that we can get a subcutaneous injection on. And then we have angles of routes. So really cool thing is that at each angle, you're going to have a different type of medication that you're going to administer. So some medications are going to go into the muscle. Those of you that have flu shots, right? Most of the time they just go into our arm at a 90-degree angle. Those are intramuscular injections. So they're just going straight in at a 90-degree angle. I'm going to find my muscle group right next to the spine and just go, whoop, go right in there. Subcutaneous injection is underneath that skin. In order to do that, I'm going to lift up on my skin and I'm going to go boop. And then just to make sure you guys could see that I am, boom, at a 90-degree. Okay. IV, I actually want to go at a 25 to like 30-degree angle because I want to go up into the vein, right? So that vein is running parallel with my body. So I need to go in, but not go too far because I don't want to pop through the vein. I want to be able to slide right into that port and just keep my needle in there. So that would be IM. ID or intradermal are not used very often, and that would be at a 10 to 15 because I'm just putting a little blip. I'm just going to go right into the skin. So you're actually going into that skin layer. If you guys have gotten a TB test or that TB shot, that would be an intradermal. All right, so to get started, we're going to talk about hematomas. Hematomas when we are drawing blood or giving medication in the vein. Hematomas can happen because we open up the vein, so that allows blood to be released. Commonly, we see hematomas in ears, or at least it's when we think about it right away. We'll think about that fluid or that collection of blood in ears because there's a whole bunch of blood vessels there. Hematomas can happen anywhere where there's a blood vessel that you've tried to insert your needle into, and it's when it happens if you're not holding off very well, then you'll get this bulb. All that blood will collect outside of that. So that is a hematoma, that blood collection. And you can see this is a hematoma in the ear, another ear getting surgery. We do not need to worry about surgically removing hematomas that are in your cephalic vein. They will go away over time. We do definitely need to apply a lot of pressure to those. Dogs will get, and cats will get hematomas in the ear if they're shaking a lot because the blood vessels in the ear rupture, and then it causes that drainage. All right, so the first injection we're going to talk about is intradermal. So intradermal, again, is into the skin, so different skin testing. If I want to do local anesthesia, if I'm just going to be working around a certain area of the animal, I can give a local anesthetic to numb that skin. Generally, that animal is probably going to be in lateral recumbency, given where, depending on that position that I need that animal in. And again, that needle is going to be at 10 degrees or even lower, okay? So I'm going right into that skin. If there's not a blub, and that blood being like a little boop, boop, little boop, boop, then it's not ID, and it went possibly sub-Q. Okay, so there, unfortunately, it's a human arm, but that gives you an idea of what that bleb is supposed to look like. So it's a small blister or bubble. Think about when you guys get water blisters, that would be a bleb, because that's fluid buildup in your skin. All right, so now we have the subcutaneous administration. Here's a rabbit getting some subcutaneous fluids. So one of the nice things about subcutaneous administration is that you're going to have that sustained absorption of fluids or medication. So sustained meaning it's going to happen over a longer period of time. So it'll slowly be absorbed into that system as the system is able to absorb it. Okay. Absorption can take 20 minutes depending on the medication or several hours. Many of our vaccinations, our rabies, our distemper vaccine, those are given subcutaneously. And then if animals are severely dehydrated, we can give fluids under the skin if we need to send them home. So outpatient, we can do that. And some of you may have even had animals that have had fluids. When we're giving fluids, depending on the size of the animal, we can use an 18 or to 16 gauge needle, which is fairly large because we just want to get the fluids in. If it's a smaller animal, of course, we might use a 23 gauge needle. For a cat, something that's a little smaller, like that gray hubbed needle we saw earlier. But if it's a large animal, we can use up to a 16, depending on what we're working with, because again, we just want those fluids to get in the skin, and we don't need to necessarily worry about speed because it's just as much as that skin can expand. So when we talk about sites of administration for sub-Q fluids, we have in our large animals or livestock, we have underneath that armpit, and even in birds, we'll give subcutaneous fluids underneath that wing, so we can do right there. Generally, cats and dogs, we have behind the nape of the neck, also above the hock joints in the back. There's some area for subcutaneous fluids where we'll give some vaccines there. Okay, with our large animals, this triangle is a good triangle for muscle. So an IM injection can be given there. But we can do some sub-Q fluids in there as well. So the blue is for the sub-Q, the green is for the IM. You want to avoid, when we're talking cattle or livestock that you're going to eat, you want to avoid those places that we eat. So just in case there's that, you don't want to be damaging the meat. Okay. All right. So when we're giving a subcutaneous injection, we are restraint. The animal, depending on how it's comfortable, it can be sitting, it can be standing, it can be sternal, right? So supporting its chest. Definitely just make that patient comfortable, but maintain control with that. So with your cats, especially, less is more. Your dogs, you might need to be putting them in a pretty big restraint. And then you're going to inject in that skin fold and aspirate. So, and when we're talking aspirating, I've injected in to my animal, and now I'm going to pull up on my plunger. I've aspirated, there's nothing in there, so it means I'm not in a vein, and now I can go ahead and inject my medication and pull straight out. Okay, so that is your sub-Q. If there's no blood, you're good, and then you can inject your fluids or whatever that medication is. Definitely hold that needle in the skin to prevent leakage. So after you've removed, you're going to pinch, so whoop, and then you're going to pinch that skin tight to assist it as it's clotting. All right, and then here's Mrs. Ritter actually injecting an animal subcutaneously. It was from the phone, so sorry, it's a little messy. Our textbooks are going to say to rub with alcohol, so that's what she did. She created her little tent, pulled back, no blood, and then she went ahead and administered, and then is applying pressure to that site of injection. Okay, so that is her sub-Q injection. All right, then we have another sub-Q injection on a cow. The cow is in a squeeze chute for restraint. Again, we've got that lateral neck. So we already have that medication is drawn up in the syringe. You can see that giant guides bevel up, poke in, aspirate. There's nothing. So we can go ahead and inject that medication and then pull out. So that's sub-Q. Now we have intramuscular. Intramuscular, you are administering at a 90-degree angle. So I have two sections, at least on dogs and cats, that I can use. I can use the apaxial, which is on either side of the spine, or I can use your quads. Okay, so either back or front. You want to administer those poorly soluble or mildly irritating medications intramuscularly. So subcutaneous is going to absorb over time. It takes a while. IM is somewhere in the middle, right? Because it's going into the muscle, but it still needs to get into the bloodstream. So you're never going to be giving fluids into the muscle. It's not going to do well. And when I say fluid therapy, we're talking about what we think about as an IV bag of fluids, okay? Even though an IV bag can also go subcutaneously. But think about on the TV shows that giant bag of fluid, that's what we're talking about with fluid therapy. So we're never going to put a large amount of fluids in the muscle. They are readily absorbed, right? So it does pick up, it does go into that bloodstream fairly quickly. And then you're going to insert 1 to 2 centimeters into the needle. You're generally using pretty short needles, so you can just go straight into that muscle, aspirate, and inject. So you don't need to worry too much because that muscle bed is pretty thick. And of course, again, I'm aspirating. And every time I'm talking about that, I'm creating suction, right? So I create suction, I pull back, and then I can administer that medication. And if there is blood, I'm changing my site, because if there's blood, that means I'm in a vein, and I'm not going to give an intramuscular medication into the vein. It may absorb too quickly for the system. It will affect either painfulness of the site, or even just how the medication is actually going to work, because how fast it's absorbed affects that body, and how the cells are processing it. That's kind of where we get into the chemistry piece. Okay, so when I'm restraining for an intramuscular injection, again, it depends on the site. If I am doing the epaxial, the animal could be sitting and I can still get in the site, but it may be easier to find it if the animal's standing. I can also put them lateral if I'm going to go into that thigh area. And I do want to alternate sites. So even subcutaneous, if I'm giving vaccinations, if I'm going to give a vaccine, you actually have common sites for like above the right shoulder, above the left shoulder, and back and back. So that way you can keep track of which vaccine you're giving, and if something has a reaction or swelling, you know which one was given where. Same thing with IM injections. I don't want to continue, if I'm going to give multiple IM injections, I don't want to continue using the same site, because that's going to also affect the absorption of the medication, and then I'm damaging that tissue. So I want to give that time to heal and kind of refresh. And again, so if there is an issue with a site of injection, I know what medication I was giving. So here are some sites for intramuscular injections. Again, I want to use the fatty piece. So in that cow, I'm sticking near the neck because I eat the back, right? So this is also very bony depending on the cow, but I don't want to damage my tissue with that. Some with our animals that we eat, you're also going to have so much time before they go to slaughter before you can actually eat them. So their last injection of particular medications, there is a time frame that they have to wait before they can go to slaughter. So here we have a dog. These muscle groupings would be the same for a cat. So the epaxials, that back piece, the hamstring group, your quads. Okay, you do need to be careful in this back leg because there's your artery and blood and some other veins that kind of run through the leg. So you do just need to be careful with the size of the animal that you don't poke through that muscle. This muscle group up front is not as common in your dogs and cats. Normally we go to this back end. And then in your horses, your IM, you can have that nice rump area, so you can inject there, and then you can also give into that neck. But you do need to be careful in your horses. You have their spine, and this is their ligament for their neck as well. So you just got to be mindful of where you're poking and prodding there, but we'll see a video on it. So this is a great video. You can see that the animal has already been dyed of where the muscle groups are. So he's going to show you where on those.
En esta representación de colores tenemos los músculos en los cuales se administran los medicamentos intramusculares. En primer lugar, el grupo muscular craneal al fémur, en el que la aguja debe entrar perpendicular. En segundo lugar, los músculos caudales al fémur, en los que la aguja debe entrar siempre paralela. Y en tercer lugar, los músculos que se sitúan en la espalda entre la cresta ilíaca y el raquis, en los que la aguja también se debe clavar perpendicular. Recuerda siempre, antes de administrar un medicamento a nivel intramuscular, debes aspirar el émbolo para asegurarte que no haya entrado sangre.
All right, and then here's another IM injection on that horse. They made a triangle.
So you're going to go right in the middle of the triangle. It'll be nice fleshy feel to it. You're staying well above the bone area. And you don't want to be up in this area at all because there's the nuchal ligament. And that ligament is what holds the head up. And it has very little blood supply. And so what will happen is the medication will be stuck in that area and can actually cause a sterile abscess. So grab our shot.
And so she did say you can cause a sterile abscess.
You're going to take your cap off the needle.
Not given the right spot.
I like to grab a little skin just to let them know I'm coming. But you're not going to go in the base of the skin. That's for subcutaneous injection. Just going to go right here directly in. Draw back. Make sure you're not in a blood vessel. And then with moderate pressure, go ahead and push the drug in. If you get blood back, just take the needle out and insert in another location.
Okay. She talked about taking that needle out and reinserting. Every time you insert a needle into something, you are dulling that edge of it. So we do like to change our needle out. So when you drop medication, you should change your needle out because going through that rubber stopper has again dulled that needle, and then you can administer. Same thing going into the skin. If I go into the skin, I've dulled the needle. I want to change it out if I have to do a re-injection. All right, and now we have intravenous administration. So intravenous, you're going into my vein or into the vein. This is the fastest route of absorption. So we definitely, if an animal comes in seizing, we want to give it medication into the vein to stop that, to be as quick as possible. We can give large volumes of solution into the vein. So this is where over a large period of time, if we can provide fluid therapy into the vein, and make sure that that works out nice and well for us. So with the vein, you're about that 25, 30-degree angle, aspirating. If there's no blood, that means I'm not in the vein. So I do not want to inject my medication. So I'm going to need to pull out and re-aspirate and re-inject. I do not want to sit there and redirect for a while. So if I go in, and I aspirate and there's no blood, I can pull out a little bit, and as I'm doing so, I'm still kind of pulling back, aspirating that plunger to see if I'm in the vein or close to it, and I might be able to do one more push in and redirection, but I don't want to sit there and just keep chopping at things because that needle is cutting into flesh, so you then would want to pull out, hold off, get a new needle, maybe even try the other side if you're doing a jug or another vein. Luckily, these things come in pairs of two, so you have multiple ways of being able to go intravenously into an animal. And definitely apply pressure after that injection to stop that bleeding, right? Assist in the clotting with that pressure, and make sure that there's no hematoma. So restraint techniques, depending on what you're doing. Here is a cephalic venipuncture. So we have a sternal recumbency, but you absolutely need to have full control of the animal because you are in their vein. So you could definitely tear their vein, and that would not be good for the animal. So you can do some severe damage if the animal is moving. So with the cephalic vessel, you're going to be in sitting or sternal position. The saphenous is going to be lateral because that's the lateral saphenous is the outside leg of the animal. And this is medial saphenous or femoral, right, which you're also going to be in lateral, okay? So your jug is in your neck, your cephalic is in the arm, and saphenous, you have lateral saphenous, which is on the outside, and you have medial saphenous, which is on the inside. The medial saphenous is also called the femoral, okay? So this is that femoral or medial saphenous there in a cat. Again, I will be in lateral recumbency unless it's a very, very large dog. Large dogs, you could do standing for that saphenous, but you do need somebody holding off for you. So here we have jugular venipuncture. This is a long, long time ago. Some of us, we went to JJC's Wet and Dwarf Farm, so they had some sheep that we were able to practice drawing blood on.
Sorry, sweetie.
Just like you're going to put that needle right in.
It's a great place.
You aspirated first? Did you pull back on the syringe?
There you go. Push it back up.
You want to hold the
It's totally fine.
and your index and middle finger here. So thumb and
Now,
index
I
and
think you want to go more to your, pull the needle
middle
most of the
finger
way out,
and
but not all the way.
keep going up,
Drop more towards my
up
thumb.
and down.
There you go. Now breathe.
There you go.
Look at that.
So then you're good. Here's an injection into the cephalic vein. So we clean off that injection site because there's a needle going in. Definitely the hands would have been washed before I touch, and I'm touching above where I'm inserting the needle. I insert, pull back, there's no blood, pull back, and there you go. Once the blood is in that syringe, that person relieves pressure so it can actually go through the vein and stops occluding. All right, and that is your injection medication. Make sure you get your summary in there and really put these things all together.